From the JAMA Network, this is JAMA Cardiology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA Cardiology.
Welcome to this JAMA Author Interview podcast. I'm your host, Dr. Roxana Mehran from the Icahn School of Medicine at Mount Sinai and an associate editor at JAMA Cardiology. It is my honor and my privilege to introduce our guests today. We have Dr. Maria Magnus, who is from the Center of Fertility and Health in the Norwegian Institute of Public Health in Oslo, Norway, and our close colleague, Dr. Sadiya Khan, who is from the Department of Medicine and Preventive Medicine at Northwestern Feinberg School of Medicine, Chicago, and she's also an associate editor of JAMA Cardiology. Welcome. It's wonderful to have you both. We are today focusing on this fantastic paper that we're very excited to highlight, first authored by Dr. Magnus and her colleagues on maternal health of cardiovascular disease after use of assisted reproductive technologies. This is a Nordic study from Konarta's group, and of course, with a very close editorial co-authored by Dr. Sadiya Khan on this, where she and her co-authors talk about when null results matter. Really, really exciting. Dr. Magnus, can you tell us a little bit about your study, just your key findings, and why is it important that you in the Nordic study focused on this particular question regarding assisted reproductive technologies?
Thank you so much, Roxana. We conducted a large Nordic registry-based study, including Norway, Sweden, Finland, and Denmark, using the national health registries, including more than 2.5 million individuals with at least one registered individual. And approximately 97,000 of these had delivered after using assisted reproductive technologies. And we had about 11 years of follow-up on average. And what we found was that there seemed to be no difference in the risk of cardiovascular disease between individuals who delivered with or without the use of assisted reproductive technologies. Actually, there was about a 3% lower risk of any cardiovascular disease among those who had delivered after using assisted reproductive technologies.
With the aging population and also the maternal age increasing and the use of these technologies enhancing over the years, understanding whether or not there is an associated cardiovascular risk after a long-term follow-up is something that everyone has been looking for, because previous studies had shown some other results. In the accompanying editorial, Dr. Khan and colleagues pointed out you had a mean follow-up of about 11 years. Maybe what we could hear is about some of the strengths of this study. Dr. Khan, maybe you could underline that for us.
Absolutely. We were really excited to see the sample size in this study as a key strength, the ability to capture all live births in the Nordic regions over 3 decades helped to emphasize that these results were consistent over time, even with technologies changing and evolving for assisted reproductive health. So that was really an important aspect of this. The second piece was the ability to adjust for key confounders. And this is where many other US studies have not been able to as robustly analyze the association between assisted reproductive technology and incident cardiovascular disease. The ability to capture pre-pregnancy hypertension, other cardiovascular risk factors that may have existed, as well as pregnancy complications that we know themselves are associated with future cardiovascular disease risk, such as hypertensive disorders of pregnancy and small for gestational age birth and preterm birth. Lastly, the ability to have follow-up over a mean of 11 years is really remarkable. While these individuals are still relatively young, the baseline age was between 26 and 30. With 11 years of follow-up, we're looking at people in their 40s, so still relatively young to have cardiovascular disease. The fact that we see no signal even at that time point is another key strength to highlight.
And I think one of the things that I was struck by, the null effect here, is the fact that despite the fact that patients using these assisted reproductive technologies were older, had more diabetes, polycystic ovarian disease, a lot more comorbidities, Still, the effect was null over time, although I still would say 11 years, we still need a little bit more follow-up. And I saw that in your editorial. We'll let Dr. Magnus talk about what she believes are some of the limitations and how we should be digesting these data in terms of how do we reflect these data to a more diverse patient population outside of the Nordic region, and in what way do these null effects have important implications, and in what ways you would like to continue to do this work in the future.
So I have to agree with you that one of the major limitations really is the still limited follow-up time, which again, as you already mentioned, is simply due to the reason when we first started achieving successful deliveries after using assisted reproductive technologies. So it'll be very exciting with more follow-up information to follow these individuals for longer, well into the 60s, 70s preferably, to get the full picture of whether they end up having or not having any increased risk of cardiovascular disease. So another limitation that I would like to highlight is that we really did only capture, for the purpose of this study, individuals who had successfully delivered. So they had undergone assisted reproductive technologies, they conceived, and they actually also achieved a delivery, meaning the pregnancy went to 20 weeks. So another aspect which I personally would find very interesting is to be able to look into individuals who have multiple attempts of assisted reproductive technologies and who remain still unsuccessful, so they never end up conceiving or at least not achieving a delivery. That's another aspect that we are wanting to look into, but in a different material, we'll have less follow-up information.
Sorry to interrupt, but it's a really interesting point that you make, particularly because we have observational data that infertility itself is associated with cardiovascular disease risk. And so I think the dose-dependent relationship that you're talking about in terms of either repeated trials or lack of success of a viable pregnancy is a really interesting future question as well.
So definitely something that we're hoping to look into. Absolutely. I would also like to point out that we did have limited information on measures of socioeconomic status. We do have a universal healthcare system across these Nordic countries, with at least in Norway 3 attempts being covered by the public healthcare system, and subsequently you have to go private. So there could be some aspect of socioeconomic gradient also influencing this association.
The Nordic registries have been so informative because of the great work that you all do in a contained sort of environment where you're able to have uniform collection of data on patients in a prospective way. The question that we always face is, how does this relate to our population? And especially given that healthcare delivery is very different in these countries, and knowing that the socioeconomic status have a very important implication on the outcomes of some of these patients, and especially on maternal mortality. Of course, down the line, their incident cardiovascular risks. Dr. Khan, how do you take this home? How do you bring this to us, to the US population, or maybe the rest of the world?
To me, one of the first things that's really helpful about the study is the reassurance that these results provide, that inherently assisted reproductive technology, while it may provide risk related to hormonal stimulation, does not increase the risk of cardiovascular disease in the short and intermediate term. But I think the question that you're asking is really important. How do we in the US start to collect data on the risks associated potentially with adverse pregnancy outcomes, assisted reproductive technologies, particularly when these may not be documented in electronic health record databases where healthcare delivery is so different and assisted reproductive technologies are often self-pay, may not be captured in claims data. So I think we leave this study with a lot more questions of how do we better set up systems that can collect this type of data, perform the follow-up that's needed, and inform our patients about their risks for cardiovascular disease.
To me, it really is truly is an unmet need to do such a study right here in the United States with collection of these data and better understanding on how to handle lots of these assisted reproductive technologies that are not fully captured in electronic databases, etc., and how we would do this. I think it's a tremendous, important next question. Dr. Magnus, let me come back to you. What are your hopes for the future? What are you trying to do from your perspective with your group from the Nordic studies?
What we're hoping to do next is really to look into the number and outcomes of assisted reproductive technology cycles and how that influences the cardiovascular disease risk. So really looking into this dose-response relationship that Dr. Khan mentioned. I'm particularly interested in those who experience repeat implantation failure and repeat miscarriages as part of the process of undergoing assisted reproductive technology. Some of these women get very high doses of hormonal stimulation, even though we're extremely excited to be able to provide these reassuring findings. It's interesting to see whether there might be any subgroups that might have any risk. So that's what we're hoping to dig into in the Norwegian registry specifically.
Dr. Khan, I think what you said about this study with regard to when null results matter is really should be underlined. Often we see less publications when there are negative results. And here's a study that enlightens us in terms of giving patients more education regarding this and being able to have really a very close relationship with our patients and disclosing information regarding what we know so far in the Nordic population. Thank you again to my guests, Dr. Magnus and Dr. Khan. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.